Yeah, once again, good evening, good afternoon, good morning, everyone. And thanks once again for joining us on our bi-weekly sessions. We once again thank Dr. Mankad and Dr. Boltauser for their continuous support to our Friday sessions. We'll start off with our first cases. The chat is open. We look forward to your suggestions and any comments and any questions to be answered. Also, please feel free to put it in the chat. I think we have 8 cases today, malformation and metabolic heavy, possibly some immune disorders too. So without further ado, we'll start off with our first case. Over to you, Debangna. Or Dr. Nikhil.
She is a 7-year-old female child with normal birth history and normal development till 3 years of age when she had some encephalitic illness with focal status epilepticus, for which the child was started on anti-epileptic, only single was it, levetiracetam and 20 mg per kg per day. The child was seizure-free in between for 3 years and now had come seizures. The seizure semiology are touch and sound induced startles with focal drop attacks, sustaining injuries to mouth, forehead, and absent seizures as well. On examination wise, child is left hemiparetic, but she is ambulant with left hemiparetic gait. Speech is relatively preserved, and she is going to school since last 2 months. So initially MRI was done. We do not have any report or of the initial MRI. So now when she had come to us, we got an MRI done.
And no neurocutaneous markers. Just
no neurocutaneous markers. No.
All right. Okay. Okay. So we have the most recent scan done last month. This is a T2 axial sequence, and you can appreciate that there is extensive abnormality predominantly involving the right cerebellum hemispheres. If you see the gyration is abnormal, they are slightly polymicrogaric or polygeric over there. Abnormal white matter changes, confluent changes with some areas of interspersed linear hypointensities on the T2 weighted sequences. There is some degree of reduction in the right cerebellum hemisphere in comparison to the left cerebellum hemisphere. If you see on the frontal region over there and the cingulate region, the cortex again is slightly abnormal on the left side too. And there are also periventricular and hyperintensities extending up to the subcortical regions on the frontal white matter. Extraocular dilatation of the right lateral ventricle out there. Coming down a bit more posteriorly, you can see the right temporal lobe is also involved. There's some also degree of atrophy, cortical atrophy there. And the left temporal region, occipital region, is relatively looks all right in comparison to the right side. And the cerebellum, at least the cerebellar hemispheres, do not demonstrate any volume loss or physical abnormalities. So predominant right-sided changes with some left frontal abnormalities, diffuse white matter abnormalities, possible demyelination or what we term as dysmyelination on the T2 weighted sequences, and there is cerebral asymmetry on the right side. The calvarium also is slightly thickened. That will be better appreciated on the sagittal sequences. If you see the frontal and the temporal parietal regions in comparison to the contralateral side, is slightly thickened over there. Flash sequences again demonstrate the similar changes which we have seen on the T2 weighted sequences, extensive white matter abnormalities, cortical abnormalities, and these ventricles again asymmetrically dilated. On the sagittal sequence, we have diffuse thinning of the corpus callosum. The brainstem and the vermis appeared normal, at least in comparison to the supratentorial brain. And again, the coronal sequences, you have the changes demonstrated, particularly on the right side. And again, the calvarial abnormalities also demonstrated predominantly on the right side. Cerebellum, as you can see on the last image over there, appears to be normal. Contrast was given, and on the post-contrast study, there were some areas of linear enhancement in the abnormal white matter areas, particularly in the periventricular regions, anterior and posterior periventricular regions. There were some nodular hyperintensities along the subependymal regions over there, especially over here and along the frontal horns. And yeah, these were the main changes on the contrast. No abnormal meningeal enhancement per se, no focal parenchymal lesions, and I could not appreciate any abnormalities in the optic nerves or other cranial nerves on contrast. Then looking at the subependymal nodules, we then got a CT scan to look for any possible calcifications. It did not throw up anything on the SWI, but still we got a CT scan, and you can appreciate, again, multiple nodular punctate calcifications along the ependymal regions, especially on the right side over there. And if you see also the cortex, I'm not sure if it's visible, but the cortex story is slightly more brightish in comparison to the contralateral side, whether that is early calcification or not. But yeah, the major findings are along the ventricles. I haven't put up any discussion slides, but based on these findings, and I had shown this case to Dr. Mankad also, we thought of a possibility of the mTOR pathway disorders, given the subpyramidal nodules are most commonly seen in these pathway disorders. I couldn't find any other differentials for the subpyramidal calcifications, and the cortical malformations may go with the mTOR pathway disorders. The white matter changes, sort of possible GFAP if it's a double hit or it's included, but it's an overall appearance of demyelination, especially on the right side. So with that, I'll open the case for the panelists and the people in the chat to comment upon now.
For me as a clinician, I'm impressed by the acute onset triggered by an encephalitis-like illness. And what you see here mainly are residual changes. And it's mostly unilateral, but the other hemisphere is involved as well. I see no argument to call this Rasmussen from the cause, on the bilaterality, whether the so-called cortex abnormalities on the right frontal area are real or also kind of due to underlying atrophy. I don't know. So this is, for me, this is an acquired non-genetic condition. Whether you call it some kind of a name or syndrome is not relevant. This is very likely for me residual.
Yeah, Eugene, Rasmussen was raised, but I think Dr. Niket, you can just elaborate if it doesn't match clinically. Is that right?
I mean, clinically, I think she does not have any EPCs. And EEG is also not focal. We don't have the previous records, I think, and that encephalitic illness is also primarily based on parental discussion. We do not have a definitive history or a documents to say that it was encephalitis. We do not have the CSF findings. The tests were done, but we did not have the reports. We tried fetching it from the parent hospital, but I think it was long back. They had a crash of system in between, so we couldn't fetch out the data. So the initial history is completely based on what parents' understanding was. And clinically, I think the seizures are more generalized. I mean, there is some focal component to it, but the seizure semiology, primarily the current ones, the subcortical myoclonus, what the child is having, touch and sound induced, but eventually dystonic seizure. So clinically behaving more like Lennox-Gastaut. But there are no Lennox-Gastaut-like EEG correlates. The EEG is completely bilateral, more asymmetric, but bilateral changes. So clinically, I'm not really convinced that this is Rasmussen's.
Yeah, got it. Thanks, Dr. Niket. Dr. Mankad, anything to add?
Yeah, I was just going to ask you all about the head circumference of this child, if there is any record of it. Because for the degree of atrophy that you're seeing, the head actually looks rather large.
Yeah, she had clinically, I think, I don't remember exactly the value, but it was borderline. I wouldn't call it
borderline large or small?
Borderline small, not large.
Okay. All right. Okay. So first of all, I think, Nihaal, what we were thinking about the cortex is probably to do with the fact that the white matter is scarred. So it appears like there is over convolution or, crowding of the gyral folds. And we have definite evidence of atrophy here with cross-cerebellar changes as well in certain locations when you were sweeping through the images. And then there is enough evidence of scarring on the left side too. So I think bilateral hit is probably the most primary differential here. This word Rasmussen's, I think, needs to be questioned a lot as to what it actually means anymore. So I don't know what the neurologists in the audience feel is Rasmussen's encephalitis, because the primary driver of that could still be a viral infection, for instance. in the absence of a known basis, genetic or antibody-wise. So bilateral, yes, and acquired is what I would go for as well. Looking at this picture again, I think everything we are seeing cortex-wise probably can be explained by the shrinking of the white matter below it.
Okay.
It looks like acquired single point insult, and we are seeing residual sequelae, as Professor already mentioned. I think a lot of people have asked SSP as a question, but the clinical course, is it progressively worsening, or is it just the seizures which is there?
The seizures which are worsening, the development is not actually.
Kader, the white matter also is not, I mean, we don't have many time points here, but I don't think the white matter signal is expanding either. And the other term that people have come up with is this Dyke-Davidoff. What exactly does it mean? It is just a hemihypertrophy syndrome, isn't it? This is not hemihypertrophy, it's both sides affected.
Yeah, hemiatrophy actually. Hemiplegia, hemiatrophy, and epilepsy.
Yeah, hemiatrophy, but this is not even hemi, this is both sides.
Yeah, bilateral.
So the next question will be, what would be the, how do we diagnose? I mean, what is the next step for the diagnosis? Biopsy, skin biopsy, or just
Genetics, maybe.
Genetics, yeah.
That was also one of the questions.
But which genetics do you do if we are thinking of an acquired insult?
Yeah, I think, yeah, sorry. Okay.
No, a biopsy will have a very poorly yield at this point. I think you will have burnt out disease, whatever this is.
I think the yield of biopsy, the question is not clear. We are probably looking at the acquired etiology, and genetics will not probably have much of yield here.
No, the only point, they said there was a residual hemiparesis even in the first insult. So whether it was there before, even before she actually presented with first seizure is not clearly known based on the history. So not sure. I mean, I couldn't say clinically, or at least based on the history, that this was insult and that is what caused the residual deficit. Probably there was deficit even before she presented first time for the medical attention. So that makes me think more in terms of genetic. But again, there are no specific clues as such. Yeah. And if it is acquired, I assume there should be some more cystic or loss of white matter or those sort of changes. These look more like dysmyelination type of changes, isn't it? Because if it was an encephalitic acquired illness, I would have expected more loss of white matter rather than dysmyelination at all.
I think Bullen's suggestion for doing an interferonopathy panel, if you have access to it, is a good one, given the fact that there is white matter change, dystrophic calcification, otherwise unexplained and no clear insult of a febrile illness at any point in life, right? So you might want to exclude that. But in terms of genetics, that's the neuroinflammatory genetics would be more relevant than any other kind of genetics.
Okay. There's a question of HHE syndrome, hemiplegia, hemiparesis. I mean, does that fit clinically, Dr. Nikhil? They tend to have unilateral atrophy though, but this is more bilateral.
Not really. Yeah. I mean, clinically, yeah. I think. Yeah.
Got it. Yeah, question of ICARD, yeah, they come on interferonopathy, so maybe what?
The asymmetry is far too pronounced for AGS.
Yeah.
I think we don't come further. It's a belief whether it's acquired or genetic. I think it's acquired, and genetic investigations are kind of a waste of resources.
Okay. All right.
Fine. Sure. Thank you.
Right. Thank you. Atuja?
Yes, sir. Good evening, everyone. We have a 2.5 years old female child born to non-consanguineous marriage with no postnatal complications, now had a history of seizure onset since 7 days of life. And these seizure episodes initially was in the form of epileptic spasms, and gradually the semiology changed to left focal seizures. And now the child has generalized tonic seizures lasting for less than 1 minute with post-ictal phenomena, and it is sleep triggered. With multiple anti-seizure medications, the seizure frequency is almost 1 episode every day. So multiple anti-seizure medications have been tried, and the child is currently controlled. The seizure episodes have decreased with lacosamide and clobazam. There's also a history of developmental delay. At 2.5 years of age, there is able to sit is present, but the child is able to sit only when made to sit. Understanding is there, single word is there, and some strains of anxiety is present. On examination, macrocephaly was present with head circumference of 54 centimeter, generalized hypotonia was there, no weight bearing, with good eye contact and some strains of anxiety, as I mentioned. Investigations were done. So next slide.
Oh, I have the MRI. We'll maybe go up the investigation of the MRI. Okay, sorry. Yeah, sorry. Go ahead. Yeah.
CCT was done, and left lateral ventriculomegaly with periventricular hypertensities were reported. CBP, LFT, urea creatinine all were normal. CPK was normal. TORCH screening was positive for CMV and rubella IgG, and child was on valganciclovir since 3 months of age. Ophthalmology evaluation done was normal. And even genetic test was sent for the child, and MRI has been done.
Okay, so no genetic results.
Genetics wise, she was, clinical exam was done. Looking for genes with epilepsy.
Yeah, I think I have that later on after the MR, so probably go to that after some. Okay, so we have the MR again done last week or a couple of weeks back. And T2 axial, and here you can appreciate a dysplastic frontal lobe over there, demonstrating dysplastic megalencephaly type appearance. The cortex is completely abnormal, thickened over there with abnormal white matter changes. The lateral ventricle again are dysplastic. The left lateral ventricle is again demonstrate this pointed appearance, slightly dilated and prominent. The right lateral ventricle also is dysplastic in appearance. There are some foci of abnormal signal changes in the frontal white matter. There is reduction in the periventricular white matter along the posterior aspect on the right side. Coming down more intensely, you can again appreciate the extent of the malformation almost involving the entire left frontal lobe. Some white matter changes again along the subcortical deep white matter and periventricular regions on the both sides. Again, the basic frontal region will also demonstrate these abnormal changes. Yeah, so predominant findings in the left hemimegalencephaly type of appearance with these typical appearance of the white matter changes, demyelination, dysmyelination. Ventricles are also abnormal and dysplastic. On the diffusion-based sequences, the cortex demonstrated slight areas of restricted diffusion. As you can see on the ADC sequences, the cortex is slightly lower in signal compared to the contralateral cortex over there. Flare sequences, just to demonstrate the abnormal white matter changes, they demonstrated rare factory of cystic changes. The posterior periventricular region has some cystic changes, possible perivascular spaces, better appreciate on the coronal sequences over there. Yeah, so yeah, these were the main findings. I think the right side also was slightly abnormal in the terms of the frontal lobes. I don't think if it is appreciated on these images, but at least over here, if you can see on the right, the third image over there, there's some abnormal gyration which we thought of, and also in the cingulate region. And then I think clinical exome was done.
Clinical exome sequencing was done, which showed no pathogenic variant. There was a heterozygous variant of unknown significance in SLC13A, which is an autosomal recessive disorder. So there was a no phenotypic match for this.
Okay, then based on the imaging, we thought these are dysplastic hemimegalencephaly type abnormalities related to the mTOR pathway disorders. And this is, I think, what was the closest differential we thought of. So I'll open the case now for further comments.
Thank you very much. I have nothing to add. I also thought of hemimegalencephaly spectrum in the broad sense. Nihaal, can you go back to the first MR slide? Just a detail. I have the impression that in the lower row on the right, the left cerebellar hemisphere is also probably enlarged, which can be together with hemimegalencephaly. Do you have perhaps a coronal view, or is that also your impression?
Yeah, not at that level, but on the axle over here, possibly, yeah.
Any skin stigmata, Nihaal, on this one? Do we know?
Nothing.
The only other differential from the mTOR associated hemimegalencephaly is when you see this should be the spectrum of the epidermal nevus in case there is any hidden skin abnormality, and then you have to look for the KRAS, NRAS, kind of those mosaic mutations. And you've put that as number 4 there, except that it's a very expanding spectrum, epidermal nevus in itself. And I think the involvement of the cerebellum would be relevant from that perspective as well. But if there's nothing on the skin, that's fine. More importantly, what is happening next? This child has seizures?
Yes, this child has seizures. Clinically, it is focal, but electrically, it is bilateral. Both the hemispheres are abnormally firing. They are independent of, and the left hemisphere is firing very, very high voltage. The right hemisphere is also firing relatively lesser. Yeah.
So they should, I mean, you will agree that there has to be discussions for an early disconnection, isn't it, in terms of outcomes, in terms of surgery and developmental problems. And the reason to provoke in that direction is what is the available pipeline and machinery for early neurosurgery for epilepsy in children in India right now in your centers?
I mean, we can offer a resective hypothesis, but I mean, hypothesis-wise, if the EEG is showing bilateral, there is no clear resective hypothesis from here. That's what I felt.
So yeah, and then my question to Nihaal was going to be, is he happy with the right frontal? Because it is underreported hemimegalencephaly that there are contralateral cortical abnormalities as well.
No, no, we saw right frontal and right anterior cingulate abnormalities.
Yeah, then the term hemimegalencephaly is wrong, isn't it?
Yeah, I mean, the primary finding was on the left side, but yeah, I agree. Right side also is abnormal, which correlates with the EEG too.
Yeah. We've had a whole series of patients who have bilateral EEG records, and yet they still go on to have a disconnection of functional hemispherotomy, and the outcomes are not bad. So you might want to look at that and see if there's an early intervention possibility.
Sure. We'll look into it. Actually, as of now, because of bilateral epileptogenesis, I have opted for keto. But then I'll have to review the literature.
Keto won't go very far with so much malformation, right? I mean, correct me if I'm wrong. I'm a radiologist, but keto won't go very far.
Yeah, but I mean, just as because she has failed multiple medications, there is nothing much to offer here. I mean, PNS, yes. Otherwise, resective hypothesis. But bilateral hemispheres are grossly abnormal electrically. They are firing at very, very high voltage indicating bilateral polyfocal electrogenesis.
So just two key messages from the sorry, choking on a biscuit. The hemimegalencephalies might have bilateral changes.
Yeah.
Secondarily, early intervention will be required if the seizures can be lateralized more to one side. So it's important to develop those. The MDT meeting that this is should have surgeons in it as well once in a while, I think, Nihaal. And I'm glad Vivek is with me. That
I think Dr. Vivek is there. I think they run a course. I mean, they run a meeting in Pune, so with the neurosurgeons. Yeah. Dr. Vivek, do you want to?
Pune is a great center for this.
I think people are asking about trying everolimus. Asked actually for reanalysis of genetics. If there is definite mTORopathy, we can identify that one of either sirolimus or everolimus can be tried.
Vivek, has it been tried? I mean, outside the context of TS-related sagas where sirolimus might shrink the mass, everolimus for controlling hemimegalencephaly related problems?
I mean, epilepsy as an anti-epileptic.
As an anti-epileptic, is that effective?
Does work as far as I understand. Maybe Dr. Lokesh can comment.
In TSC refractory epilepsy, a combination of vigabatrin and everolimus actually works better than just the vigabatrin only. So there are studies to support this hypothesis, but variable. We'll have to maintain a particular level of everolimus, and those things have to be followed. But yes, it works. But outside of the TSC, we are not sure.
Yeah.
All right, I think Dr. Alexis Sturgeon also has some.
Yeah, sirolimus or everolimus, yes. This one quite extensive usage.
All right. Dr. Nikki, we'll just wait for the generics and probably take it further from there.
Yeah. Already that's in the process. So hopefully we'll get something.
Any somatic abnormalities in terms of asymmetry in the limbs?
Nothing actually. This kiddo has nothing.
Okay.
Nothing external.
Okay. All right. Thank you.
Thank you.
Yeah, Anas, over to you.
Hello, good evening. This is a 3-year-old child born to non-consanguineous parents, third in birth order, development normal premorbidly. On June 1st of this year, parents noticed the child had behavioral changes in the form of excessive fear, shyness, and he was complaining that he's seeing a tiger. This happened for like 2 days, followed by eye movement restriction in all direction. Same night, he had right focal clonic seizures, which got controlled after IV medications. He was admitted at a private center. There, he stayed for almost 10 days. In that, on day 3 of illness, he had another focal status, after which child regressed cognitively. He had received IVIG, IV methylprednisolone, rituximab, cyclophosphamide, MMF, and showed no response. He developed dystonias and later hyperthermia, which only responded to bromocriptine. This whole event lasted 15 days. At this point, his seizures were well controlled. 1 month later, he started to have myoclonic jerks, which started to gradually increase in intensity to present current state. Currently, they're refractory to multiple AEDs. Currently, the child is encephalopathic, has excessive startle secondary to sound, and persistent myoclonic jerks, left more than bilateral.
Okay.
Child has been evaluated in the lines of autoimmune encephalitis at the different center, and he has presented to us with excessive jerks.
Okay. Yeah. So you can go up with the follow-up after the scan, Anas.
Yeah.
So this is an external scan done initially and slightly pixelated, but what we can appreciate is bilateral hyperintensities in the thalami over there, predominantly along the median aspects. Going down, you can again appreciate some hyperintensities along the inferior aspect of the third ventricle. I could not appreciate any malformations, no abnormalities in the cortex or any white matter in the bilateral cerebral hemispheres. Coming down posteriorly, brainstem did not demonstrate any signal changes. Cerebellum also did not demonstrate any signal changes. But the diffusion again had some additional changes, especially in the left parietal region, possibly also in the right parietal region over there, but more clearly seen in the left posterior cortex, the left parietal lobe. You have these cortical, subcortical areas of restrictive diffusion, and these two images are clear. So they again just to highlight the signal changes in the bilateral thalami, and on the even these demonstrate slight areas of hyperintensity on the diffusion weighted sequences. The thalamic lesion did not demonstrate possibility to shine through, did not restrict on the ADC sequences, whereas the cortical changes demonstrated restriction. I don't have them up there. SWI in contrast did not demonstrate any findings. Sagittal image just had the thinning of the corpus callosum in the region of the body over there. And the angio and the veno, I only have MIP images. I cannot appreciate any significant abnormalities on these sequences. So based on that, Anas, yeah.
His CSF analysis was done, which was normal, and CSF extended panel for viral and bacterial was also negative. They had done CSF autoimmune panel, which was negative as well. Ammonia lactate TMS was normal. JAD was also done, which was normal. EEG was done at our center when the child was referred. It showed bilateral posterior dominant spike and slow wave discharges with post-spindle formation. ESR is normal. Currently, we have sent whole exome sequencing with mitochondrial. The reports are awaited.
Okay. We have a follow-up scan. Maybe that will maybe explain why genetics was sent. What was the duration, Anas, between both the scans?
Around 1 month, sir.
Okay, and the interval time period still seizing. Still
Yeah,
myoclonus.
yeah, continuously seizing myoclonus seizures. As of now, child is still seizing.
Okay. So on the follow-up scan, you can appreciate some areas of cortical abnormality, cortical areas of diffusion, bilateral frontal regions, parietal regions over there. More better appreciate again on the left perisylvian region. Also, the occipital cortex was again, the median asterisks were demonstrated these bright signal changes. Thalami, also the pulvinar thalamic nuclei had some areas of restricted diffusion. The medial temporal lobes also, that especially on the left side, the amygdala over there was slightly bright on the diffusion sequences. And with corresponding the changes on the flare, now again we have bilateral thalamic hyperintensities. More, you have again hyperintensities in the cortical regions over there, in the along the perisylvian regions, the insular cortex, the bilateral amygdala, medial temporal lobes also demonstrated these flare hyperintensities. And the T280 sequences demonstrate interval progression of reduction in the volume, possibly some attribution to the treatment given within this time period, but you can see that there is a significant reduction or interval reduction cerebral atrophy in comparison to the first scan. And then cerebellum also had some degree of volume loss, but the major findings of volume loss were in the supratemporal brain, with some mild hyperintensities in the thalami over there. And then the possibility of autoimmune was raised. We had, I think, ruled out most of them on the autoimmune panel. Then given the second scan, we thought of possibility of Paul-G-related disorder, given that the child was progressively encephalopathic with myoclonic seizures, which can present with these bithalamic lesions, can have these cortical abnormalities. The periodontic sign is also a finding which is not seen in our case, but can be seen in the Paul-G mutations. But predominant changes are in the bilateral thalamic regions, the cortical regions, especially the occipital lobes, given with the clinical picture of progressive encephalopathy and myoclonus. These were the other differentials. I think the only one which consideration was viral encephalitis. I don't think any others, or the thiamine sensitive disorders were the other possibilities. I don't think others fit into our spectrum of disorders here. So on that, I'll open the case for now for the evaluation. Spectroscopy wasn't done for either scan. I think that was the question on the chat.
Yeah. So I think the question here was, this child received extensive immunomodulation. So if it is the first image, it was all based on the first imaging, what was done on the clinical presentation of acute encephalopathy and multiple seizures. So based on this sort of any handles radiologically, clinically, generally the normal NMDA receptor encephalitis, they don't present with too many seizures. Movement disorder will be much more prominent. If it is monosymptomatic, just encephalopathy and seizures, no persistent psychosis or movement abnormality, or NMDR would be less likely, which is the most common autoimmune encephalitis. So immunomodulation to extent of cyclophosphamide and mycophenolate mofetil on ongoing basis, I think we'll have to be very careful while giving more extensive immunomodulation in absence of a good handle in this kind of progressive encephalopathy with these thalamic changes. How frequently do we get this kind of relative thalamic changes in the autoimmune encephalitis?
As far as you know, not very frequent. Dr. Lokesh, Dr. Mankad wants to add. The only thing I could think of was the NMOSD, which has more central involvement, but not the typical autoimmune one.
Yeah, that is right. I would agree. I think primary thalamic involvement to this extent would be unusual. When you first showed the pictures of the pyramid line changes, I was thinking aquaporin 4 as well, because there are areas of aquaporin 4 expression. I guess that's been excluded.
Yeah, the entire autoimmune panel and the antibodies were negative.
Yeah, but then the evolution of that into a lot of brain atrophy as well. They might have been given steroids, but there is a lot of atrophy by the time you show the second picture. This could be steroid-related changes at this point. It doesn't kind of go in that direction. But when you say autoimmune, what are we saying then autoimmune-wise? Just non-specific autoimmune, or are we thinking about specific entities? At a fundamental level, all post-viral changes are autoimmune in its own way, right?
Yeah, infectious.
No, antibody-mediated kind of thing was thought of initially, and because there is no significant improvement and the child remained encephalopathic in spite of such extensive immunomodulation, when we saw a second opinion when they came for, we thought of more likely to be a mitochondrial depletion disorders with this kind of asymmetric onset thalamic changes with a restricted diffusion significant.
Yeah, the only thing which was on the follow-up scan were these neuro restricted diffusion, which I wouldn't, if it was just an autoimmune disorder, I don't think it would be present.
And on the follow-up, was the child seizing when you did the scan, the diffusion restriction scan?
Yeah, the child was, I think. Anas?
Yes.
Yeah.
Yes.
So that could be related
So
to
some
the
of them, yeah.
excitotoxicity per se, right?
Yeah.
But that would be unusual for a sequela of autoimmune encephalitis as well. But it still means that there might have been a viral prodrome to all this. Isn't it? You would call this alert, wouldn't you?
No, I wouldn't. This is more cortical involvement. That is more white matter subcortical involvement.
Correct. Okay, I agree with that. So if this is cortical diffusion restriction in the context of a seizing child, could we add much to this? What is the MOG status?
Negative.
Negative. Okay.
There's a comment from Dr. Prerna. Would it fit into progressive myoclonic epilepsy syndromes? Biotin, thiamine.
It does actually.
He was on a good dosage of supplementation, but he continued to have seizures and no improvement in encephalopathy.
By now, Nihaal, you're picking up hippocampal sclerosis and everything, isn't it?
Yeah, but there's, I think, uniform atrophy. So I don't know if that's just selective or it's part of the generalized atrophy over there.
So it's going to be antibody negative autoimmune encephalitis and its sequela.
Or mitochondrial disorder.
You mean a Polg kind of mitochondrial?
Yeah.
All right. Okay.
The only thing that the child had EPC wasn't there, I think, Dr. Lokesh.
EPC was not myoclonus. Continuous refractory. He started off with focal seizures and then went on to have generalized. Almost 24 hours he was in focal status and then generalized seizures.
Yeah.
Vivek or any other clinicians out there, for the initial imaging, how much of immunomodulation you would actually go ahead and do? Okay.
Yeah, I don't think.
Okay. Yeah, fine. Okay.
Yeah, all right.
The next one.
Okay. Okay.
Thank you.
Yeah, Ramya, if you're there, go to you.
Yeah. Hello, everyone. So this is a 10-month-old female child who presented with microcephaly and developmental delay. So this microcephaly was noted when the child at around 32 weeks of gestation age. So by that time they couldn't do anything, so they continued pregnancy. So they came to me at 10 months of age with developmental delay and then microcephaly as such. Then clinically, this child has vision is severely impaired. Child is not able to fix and follow. Hearing is okay. Social smile is present, but not particularly to the mother, just to the voice she smiles. Partial neck folding is attained. And then because of the imaging findings, we were thinking,
So
we'll come back. We can come back.
Yeah. Okay, scan at 10 months.
Yeah.
All right. Okay. So we have T2 axial sequences on there. Some degree of cerebral atrophy in the bilateral hemispheres and extensive white matter abnormalities. Some areas, so possibly of refractory changes. So the FLAIR sequences might be helpful. But you can see that the frontal cortex is expanded. There are hyperintensities in the bilateral frontal lobes. But extensive white matter changes, T2 hyperintensities in the bilateral hemispheres. Also, the temporal poles, you can appreciate that the white matter is again slightly hyperintense. Again, possibly some refractory changes resulting in widening of the gyri over there. Deep gray nuclei could not appreciate signal changes, but again, you can see this, the central white matter is also abnormally hyperintense for a 10-month-old child. So there is some delayed myelination going on there. So cerebral atrophy, extensive white matter changes, possible refractory changes over there. Some cystic changes in the periventricular region, some hypointensities in the deep white matter. I think the other sequences might be helpful. Yeah, so FLAIR, you can appreciate the refractory changes in the frontal lobes, the temporal poles over there, some subfrontal cysts, some periventricular cystic lesions, and some degree of dilatation of the lateral ventricles more along the mid and posterior aspects. So lateral sequences, you have a diffuse thinning of the corpus callosum, also reduction in the volume of the brainstem. And on the SWI GI, we didn't have this is a GI sequence, we didn't have a SWI, but you can appreciate there are areas of blooming artifacts in the bilateral periventricular regions, the centrum semiovale, also along the right lateral ventricle out there. So based on that, we're thinking of differentials of these cystic changes first, and these were the list of differentials. Interferonopathies are commonly seen causing these changes. Congenital CMV, I think that was evaluated for CMV, but these are the other differentials which can present with these refractory extensive white matter changes in the bilateral hemispheres, predominantly in the temporal lobes. Calcifications, I'll just skip this slide. I think there's one more. Yeah. So I think based on the images, I'm primarily thinking of interferonopathies, these extensive white matter abnormalities, these foci of blooming changes on the SWI sequences, which correspond to hypointensities. And these images at least appear similar to our case and the paper from Dr. Mankad. Yeah, so these were the main differentials which we thought of. I think interferonopathies was the primary one. Less likely CMV, but again, open for interpretation now and for the panelists to comment upon.
Hey, I had one additional differential diagnosis called leukoencephalopathy with anterior temporal cysts. It was initially reported by a group from Germany in siblings as a CMV mimic, and the gene has been later determined as RNASET2. So they make also
RNASET2 test. Got it. Thanks, Eugene.
But that is also an interferonopathy, isn't it?
No, it's kind of
I
think the gene is expressed in vessels.
I thought it was in the spectrum.
But they commonly also have hearing loss and is that right? Speech delay, I think, the RNAs2s.
No, they have normal hearing.
Okay.
Well, there is always a spectrum, but principally the hearing is normal. I mean, you will process to genetics anyway, I think, and then you will find all these options, most of these options.
Yeah, we are planning to send genetics because if CME, I wanted to rule out CME because I can give some treatment for that. So anyways, that has come out negative. So I'll go ahead with genetics.
You might want to check the link I've sent. I think the RNAST2 is in the spectrum of the interferonopathies. It's a subtype.
Okay, thank you, Dr. Mankad. So yeah, Ramya, we are going towards the genetic cause because
Sure. Yeah, thank you. Yeah.
All right, thanks.
Thank you.
So Sayoni, over to you.
Yes. Good evening, all. So this is a 1-year-old girl who is currently developmentally normal. She had episodes of focal seizures in form of bilateral eyelid clonic jerks at 4 months of age. The episodes were infrequent that time, 2 to 3 episodes, but they didn't recur further. And however, since last 1 month, the child had episodes of predominantly left focal tonic seizures with lip smacking. The episodes would be very brief and the frequency was maximum up till 4 to 6 episodes per day. And there was no history of any early handedness, no focal motor deficit on examination. And currently the child since 15 days has been started on oxcarbamazepine and she is well controlled on that. So so the MRI for discussion.
Okay, but these are well controlled.
Yeah,
as
yeah.
of now.
With one anti-epileptic, yeah, it's completely
Okay.
controlled. Yes.
Okay. And what was the time frame, the age, the recent one? I think
This is
last month.
this is recent only. Like
Okay, so
yes.
got it. So yeah, so the main abnormality here is over here in the corpus callosum, actually extending from the cingulate region. I think the coronal sequence will be better appreciated. You can see that there is these T2 iso to slightly hyperintense abnormality over there along the midline, going down and also infiltrating into the corpus callosum, the body and the isthmus of the corpus callosum. On the player sequences, it is T2 hyperintense, and you can see that it is infiltrating, going up to the corpus callosum, causing some mass effect. The DWI, I could appreciate a focal area of restricted diffusion, which corresponds on the ADC sequences. No calcifications on the SWA sequences. Contrast, it did not enhance much. There was a peripheral area of cystic foci along the lesion over there. And again, the parietal sequence for the contrast sequence, the contrast over there did not demonstrate any abnormality in terms of enhancement. I think I don't have a follow-up. We're looking of the possibilities of a low-grade glioma or a focal cortical dysplasia. Is that right?
Yeah. Yes. Yes.
Okay. So focal cortical dysplasia again. Would the clinical thing would corroborate, given that less seizures have been controlled by one epilepsy?
He had infrequent at 4 months of age, but in between no investigations were done. So it's a recently since 1 month the seizure has recurred and now she is being controlled. So initially in the part of any they may get, but over the time it can worsen.
Yeah. So, Dr. Just thinking that such a large dysplasia is, I mean, I'm looking more towards low-grade glioma. Pankaj, what do you think?
Yeah, I'm just trying to figure it out, frankly. I think you're in that spectrum of focal cortical dysplasia plus minus tumor. So
yes.
Exactly. Surgically, this might be a difficult one, but in spite of the fact that you're controlled on monotherapy, if this is a targetable lesion, it should be resected. Isn't that correct?
Yes.
That's the current thinking, isn't it? So
but given the location, such an important.
Yeah, but it's
critical. Yeah.
Surgeon, right, to decide what they can do or not. It's good that the child is controlled with one therapy, one line, but if it's a lesion, whether it's an FCD or a tumor or somewhere in between, like an ILA 3B, yeah, worth talking to the surgeons if something is possible.
Okay. So as the
to follow it up, sorry, what's a follow-up plan? You'll have to still follow it up as a low grade for some time, right?
Okay. Yes, sure.
Yeah.
So, are there any indicators like how to differentiate between the two on the like the cingulate gyrus low-grade glioma or the FCD based on MRI, and any pointers for that?
There might be a role for spectroscopy here. I think it's a good size lesion for that. Second, if it were enhancing, it would kind of favor tumor over. But I don't know. Are you showing enhancement there?
No, there's no enhancement.
No enhancement. Only a diffusion restriction foci was.
That's diffusion there on the top.
Yeah. Yeah.
Nothing, but we still have to. We will follow it up as a low-grade glioma.
Okay.
Yeah.
Okay. Thank you.
Okay. All right. Thank you. Dr. Vivek, over to you. Dr. Vivek, are you there?
Yeah, sorry.
Yeah.
So this is 17-month-old baby who I have been seeing since few months age, and she had presented to me with initially with polymorphic seizures, initial focal, then spasms, and later hypomotor seizures as well, which have stopped now on 2 medications for the last 5 months. She continues to have central hypotonia, and she does have significant dyskinesia as well, along with the global delay. So it was her MRI, and wanted to discuss. Interestingly, her first MRI, which was done at 3 months age, was not matching with the gene which came later, as it was showing, and I don't have the those films now, but it was showing agenesis of corpus callosum. So if you show the MRI now and maybe the gene, then we can.
Yeah. So MRI again, extensive cortical malformations in terms of extensively or their pachygyric appearance involving the bilateral hemispheres. There's almost a colpocephalic type appearance of the lateral ventricles, some abnormal white matter foci in the periventricular regions out there. The main finding or the giveaway here is the enlarged or bulky dysplastic corpus callosum, the brainstem hypoplasia, the pontine hypoplasia, some degree of inferior Roman hypoplasia also. And cerebellum also, there was some asymmetry of the cerebellum. If you see on the coronal sequence over here, there's some abnormal foliation, maybe slightly dysplastic, also reduced in volume. So predominant cortical malformation extensive in the supratentorial brain in form of lissencephaly pachygyric complex abnormalities, colpocephalic appearance of the lateral ventricles, dysplastic megacorpus callosum, hypoplastic brainstem, and cerebellum. And the gene was present at the time of the scans, and this was the gene at that time, Dr. Vivek, if you want to. It was done before this this scan, so yeah.
Yes, it was done before this scan, and I told the geneticist that it's not matching because this child has corpus callosal agenesis, or very small corpus at 4-month age. But then after this, I again repeated the MRI around 1 year age, and this is how the callosum looked. So
Yes,
that was.
So it's an imaging match, at least, yeah.
Yeah. So like the corpus callosum must have grown over the next 6-8 months. That was surprising, from 4 months to 1 year age.
Now, was it reported as agenesis, or was it based on the films? Maybe sometimes the sequences might have missed the corpus callosum.
But you won't miss a mega. So definitely it must be small or thin.
Okay.
Yeah, at least we're not normal.
Mm-hmm.
Thinner than normal.
Yeah, if anyone has any experience with this mutation now.
Nihaal, I did not know what the final mutation was, but you have all the features of a microtubule/tubulinopathy, right? And which is in the spectrum. MAST1 is a tubulin-derived protein, isn't it?
Yeah, the microtubule, yeah.
Yeah. So in that respect, if you were to do a tubulinopathy panel, would it be included? What panel was done for this one? What was done? It came as an uncertain.
We did a whole. We came whole exome trio.
Okay.
But that was done before this MRI.
Yeah, it was done before this. So because the match was not there clinically because of the callosum. Because I wrote, I think I wrote corpus. Yeah.
It's a huge corpus callosum on this case, isn't it? Quite fascinating, actually. It's all over the place. But also the hindbrain malformation. Do you have an axial through the brainstem? Yeah, there it is.
Yeah.
I was looking for asymmetry.
Yeah, but I think it's a pretty, textbook case, I guess. Yeah, all right. Thanks, Dr. Vivek. Dr. Prerna, over to you.
So this is a 4-year-old girl who presented with refractory seizures and abnormal movements 3 days following a febrile illness. There was no preceding history of rash, sore throat, no visual difficulties. There was no history of any joint pains. And actually, she was referred as status epilepticus or refractory status. But actually, she had more of movement issues rather than seizures. She definitely had right focal seizures, which were affecting mainly her face and right upper limb. But the left upper limb and left lower limb had sort of chorioathetoid movements. And on examination, she was encephalopathic. Her
Her EEG, I think it was taken probably post phenobarbital, so it showed electroclinical dissociation. There was just slowing on the EEG, but there was no epileptiform discharges that were seen. She was initially evaluated for infections, so blood markers as well as CSF biofire was negative. Her CSF NMDR is awaited, so we worked up for autoimmune when the infection screen came negative. MOG and NMO was negative. And so we can just, so initially she was started, so these are the movements that she was having. So there was sort of a, I don't know if it's very clear on the video, but there was a writhing sort of movement that was affecting her chest wall, as well as her left upper limb and right lower limb. So thinking that this could be autoimmune, we started her on steroids. And Dr. Nihaal, do you have the initial, like I had just sent some snapshots of the previous, this was the initial MRI.
Yeah, so this, the initial MRI again, from the film slightly pixelated over there. But you can appreciate on the flare and the axle, the T2 axle sequences, there was the hyperintensities or edema in the cortex, the bilateral parietal regions. Also, better appreciate on the T2s, the left caudate nucleus and also the putamen had some hyperintensities, focal hyperintensities, and there were bilateral cerebellar edematous changes on the T2 and flare sequences. With the diffusion various sequences, again, you have these areas demonstrating restricted diffusion. So all of them have some degree of restricted diffusion. Contrast, there was some leptomeningeal enhancement in the cerebellar hemispheres, the cerebellar abnormalities. I'm not sure if they're slightly attenuated areas of leptomeningeal enhancement in the, especially in the parietal regions, the perisylvan regions, but those were the main findings. Yeah.
Yeah, so the repeat scan was done on day 3 of steroids. So the child clinically improved, actually. She was not having a lot of these movements and her seizures had subsided on levetiracetam and lacosamide. And then in the scan, we can discuss, Dr. Nihaal, just showed progression of these lesions.
Yeah, so follow-up scan done 3 days into steroids, you had progression in the lesions. You can appreciate that on the diffusion various sequences, bilateral frontal lobes, bilateral parietal lobes, predominantly in the cortical regions, demonstrated these areas of restricted diffusion. Coming down along the central aspects, you have bilateral basal ganglia involvement now, more along the left side. But you can see also the left temporal lobe, the occipital lobe has these areas of restricted diffusion. Cerebellum did not demonstrate any new changes. Flare sequences demonstrate the corresponding changes on diffusions. Again, bilateral basal ganglia, dorsal striatal involvement, predominant dorsal striatal involvement, also cortical subcortical involvement in the bilateral hemispheres, left more than the right side. Some thinning of the corpus callosum out there. Again, do not appreciate any significant enhancement, no focal areas of enhancing foci, or no leptomeningeal enhancement or meningeal enhancement on the post-contrast study.
Yeah, so her initial metabolic workup was normal. So she had a normal lactate and ammonia. Her CSF routine analysis was normal. She had a low TSH, but her T4 was normal. So probably that is something related to her acute state. The only positive finding in inflammatory this thing was that she had a ESR of 30. But all other, so we sent off, so initially the MRI was reported as query vasculitis. So we sent off basic ANA panel and that was negative. Basically, you know, we're still treating her along the lines of autoimmune encephalitis, but after, and she was put on mitochondrial cocktail. So biotin, thiamine, carnitine, CoQ10, but and I think after Dr. Nihaal, we sort of had a discussion. I just increased the dose of the biotin thiamine. At present, she is conscious. She's responding to verbal, like she's responsive, but she's, she doesn't have any movements. She now has hypotonia and loss of reflexes, actually. She has no bowel bladder control.
I don't think we did a spine, right?
No, we didn't do a spine.
Okay. All right, I'll open the case. Yeah, these are the differences we thought of. Yeah. post-infectious, infectious viral encephalitis was more common one based on the first scan. Then autoimmune panel, the MOGs and the NMDRs. Biotin thymine based on the progressive changes, but I think the child is not completely responsive now. Is that right, Dr. Pino?
Yeah, so she's not encephalopathic. She's come out of encephalopathy. She's been extubated, but she's not doing very well. So she has additional findings of lower motor neuron lesions as well. Clinical findings as well.
Does she have element findings now, or is?
Yes, sir. So she has loss of peripheral reflexes now, sir. And no bowel bladder. So she's catheterized still. She has no bowel bladder function.
Okay, that could be part of encephalopathy, but we have not done a spinal cord.
No, we have not.
So some of your enteroviral, even influenza and JE, those kind of things can have anterior cell involvement as well, especially in the cervical cord. So some form of viral would be more likely here rather than this one, because asymmetric patchy cortical involvement.
So, but the biofire, which is covering most of the common ones, it is negative, sir.
Will never be. Yeah,
that's right.
Like she had this. So when I spoke to you last, I had mentioned this dengue being positive, but apparently that was a fake report. So she wasn't actually dengue positive.
Okay. Okay. Kish, any other inputs? Is there anybody?
No, I think Sridhar's suggestion for even kind of, because we are baselining everything to look for natural killer activities for HLH, worth kind of looking at, I think. But otherwise, you guys are working on the right differentials. Though there's such a wide possibility here, right?
Yeah.
Should we get a spine scanning done? Would that be helpful? I think.
Your anti-on-cell involvement, if you have anti-on-cell involvement, probably that might help us in certain extent. So narrow down the list of conditions which will have both brain and spine, and
it is quite gray matter, isn't it?
Yeah.
What we even the deep gray and the cortical gray. Almost.
I was just wondering that whether, so I added valproate for her movement disorder because it wasn't getting control with anything. But her LFT is not deranged. So if we are thinking of something like MELAS or mitochondrial related, could my addition of valproate or any of the medications worsen this clinical picture?
I think you can try, but it will be helpful. You will see. The situation is, of course, not satisfactory, but if I understand you well, the overall situation is slightly improving.
Yes, sir.
So sometimes the EEG, neurophysiology, and imaging lags behind the clinical improvement. So I think you can kind of afford to wait and see and repeat your investigations, of course, in a short while, but I see no immediate other action now.
Okay. So would a time interval of maybe 7 to 10 days before I repeat the imaging, would that be, and maybe the clinical findings might change by that time, because this sort of loss of reflexes and other things might be transient.
I think this is a reasonable interval.
Okay.
Okay.
And so just one thing. So should I progress with any other immunomodulation now, or should I just? So we've given her steroids and IVIG. Right now, she's responding to verbal commands. But should I proceed with any further?
So you know, this damage, and we all know now this is all cytokine storm.
Yes.
And methylpred and IVIG is pretty useless here. I'm sorry to say. And what I would have done on day 4, this is like mini fires, and which sort of has left this. And I would have on day 4 done a IL-6 level, or even without that, tocilizumab would have been better choice rather than steroids and IVIGs. They don't work. And I won't push for any imaging or anything. I'll just wait and let her, because this is going to atrophy this brain. And you won't, I don't think one has much left to do here. This is how the cytokine storm is.
Okay.
This is not an antibody mediated. This is a cytokine mediated damage. That's what I feel.
Okay, sir. Thank you.
It's too early in the illness, few days illness, frequent seizures, day 4, day 5. I don't know even they work. People say they work, anakinra and tocilizumab. So I just feel these drugs should be given initially for these site of presentations and imagings rather than methylpred and IVIG, which should be more for illnesses which present after 5-7 days, with less of diffusion restriction, more of inflammation.
Okay, sir. So, but with fires, actually, wouldn't seizures be the main this thing rather than movement?
Yeah, it's not fire, it's a continuum. So fires, what fires we think of fires is a very bad fires. And there is this small, maybe there's a mini fires, or there's some form of where you just have few seizures and then it dies off. So it's just the cytokine syndrome. Somebody will probably name them as CNS cytokine syndromes.
Okay, okay, sir.
Okay.
Okay,
all right.
sir. Thank you, everyone.
Thank you, everyone. Yeah. Yeah. And to our last case, Kirti, over to you.
Yes, good evening, everyone. So this is a 3-year girl who was born to non-consanguineous couple who had a baseline developmental delay, never evaluated for that. Like development, like she had started walking at around 3 years of age, and her speech was only meaningful words till that age, and no seizures ever. And then at the time of presentation to us, she had fever for a very brief duration of 6 to 8 hours, and then suddenly had loss of consciousness, altered sensorium, very fast breathing, which was actually acidotic breathing when we saw her in the emergency. And she was totally encephalopathic, deeply encephalopathic. That GCS was 8/15 with acidotic breathing, and we had to intubate her. And her initial workup on presentation was like she had hypoglycemia. Her sugars were 23 on presentation. Severe metabolic acidosis with pH of 6.8. Bicarb was hardly 4 or 5, and an ion gap of 35. So it was a high anion gap metabolic acidosis with normal lactate and hypoglycemia. So immediately we thought it could be something metabolic because there was also a background of developmental delay. And ketones were done, which were very high in the urine. So it was a ketotic acidosis. And but the sugars got controlled very easily at minimal GIR. She was not requiring very high GIR to maintain sugars. Like only on dextrose 5%, the sugars could be maintained. We thought whether the child will require CRRT because of the severe acidosis. However, by giving bicarbonate correction and by appropriate fluids, and to promote the anabolism, we had also given her insulin. Giving her dextrose 10%, we also gave her insulin. And she came out of that crisis almost in 36 hours. 24 to 36 hours, the pH started improving. And by 72 hours, we could extubate her. And we had sent metabolic TMS and GCMS in the critical samples. So I think we can discuss the.
I have them after the imaging. So imaging wise, the predominant changes were in the bilateral globus pallidus, demonstrating this area of restricted diffusion. As you can see on the ADC sequence, also there is corresponding low signal over there. On the flare sequences, also could appreciate the basal ganglia or the dorsal striatum also slightly bright than what we normally expect, but the predominant changes were in the globus pallidus. For the basal ganglia itself, bilaterally demonstrated some degree of hyperintensity. Dentate nuclei, what was the age, Katie?
3.5.
Yeah, they were slightly again bright for a 3-year-old. The dentate peridentate white matter was slightly on the brighter side. And on the sagittal sequences, we had some thinning of the corpus callosum, the mid and posterior segments over there. possibly some reduction in the volume of the midbrain. But yeah, the predominant changes were in the basal ganglia, in the globus pallidus, and also some changes in the dentate nuclei.
Yeah.
So these were the main findings. Just to add, I don't have a T2 axle, but there was some degree of frontal cortical atrophy too. Yeah, if you can see on the ADC sequences, yeah, there was some frontal cortical atrophy with these changes.
Okay, so clinically, like by the basic metabolic disturbances, ketotic acidosis with a normal lactate ammonia, we thought it could be organic acidemia. We thought it could be ketolytic defects of ketone metabolism. These were our very close differentials. Glycogen storage disorder, all those things were very less likely with a normal lactate, no hepatomegaly. So we wanted to correlate the imaging and the metabolic reports. So the TMS came. Based on the imaging, we thought of methylmalonic acidemia because of the acidosis as well as bilateral globus pallidus involvement. However,
and hyperglycemia as well. Hyperglycemia also is more often seen with MMA.
Yeah. Yes. Actually, the child presented with hypo, and later he went into hyper. The metabolism change, yes. So that is what we thought. But the TMS was suggestive of elevated branch-chain amino acids. The leucine, isoleucine, and valine were elevated. However, the same correlating metabolites for branch-chain amino acids in urine GCMS were not corroborating. So we couldn't fit the condition into a single metabolic condition. And whatever metabolites were present in the GCMS, like hydroxyvaleric acid and other ones, which were not corroborating with the TMS. So there was not a single metabolic that we could pinpoint to. There were differentials raised like beta ketothiolase deficiency on GCMS report, but on discussion with biochemist, he said that in that condition, Tejal carnitine should be increased in TMS, which was not there. So there was a mismatch in the TMS GCMS reports. Also, there was high uric acid in this child. It was around 15 or 16, which got corrected after the acidosis got corrected. So as of now, we don't have a clear-cut metabolic answer. We have sent the genetics, clinical exome we have sent. We are considering it as MSUD based on the raised branch in amino acids in the TMS. My main question was whether the imaging findings can be seen in intermediate type of MSUD, or is there anything, any imaging clue for any other metabolic disorder?
Yeah, so Kirti, these are the differentials for the globus pallidus changes which you have seen. Organic aciduria, as I think Bulent has outlined, MMA is one of the most common disorders. Beta ketothiolase, again, another possibility. No lactate elevation, so PDH is not a consideration. These other isovaleric acidemia also can have bilateral globus pallidus changes. Regarding the question of intermediate MSUD, I found some cases in literature. This was one which had symmetrical changes in the globus pallidus, slightly faintish in comparison to our case. Again, this is from Vandernaaf's book, which had these bilateral globus pallidus changes, but also had dentate nuclear abnormalities. And this is more extensive involvement of the abnormalities over here. What Vandernaaf has mentioned is the intermediate ones usually have a more resemblance of a Canavan type disorder, has more white matter abnormalities, can have these deep brain nuclear abnormalities. So there are some cases which have selective involvement of the deep brain nuclei, and the other differential for which has seen in the previous slide. So I think to consider all, wait for the clinical exome, whole exome is what I would think of, but I'll open the case for any further comments.
Has anyone gone and looked at methylmalonic acidemia cases and what happens to their dentates? I haven't.
I think they are slightly hyperintense, if I'm not mistaken. There's some delayed myelination over there. There's some hyperintensity, not delayed myelination, but
yeah. Branch-chain amino acids, this one, leucine, isoleucine, and valine, the 3 branch-chain amino acids were elevated in the TMS.
There's enough biochemistry to go in that direction, isn't it, guys? Instead of looking for other differentials. Whatever is happening in this kid with branch chain elevation and all that. I think that's Bulen's question as well, basically. Because then, you start looking at globus pallidus and other things. There's a list of possibilities, but you have elevated branch chain amino acids, right? Where would you stop?
So because if I have to start a diet for this child, right now I'm giving a low protein supplement, but ultimately I cannot wait till the report of the genetics to give her the proper diet. I am thinking it to go in terms of MSUD. Just wanted to discuss that point.
I think continuing at least 1 gram per kilo of protein and discussing with the metabolic specialist until we get all the answers. And here, I think probably the role of rapid genome sequencing, which comes in a week's time, actually that's worthwhile in this sort of situation.
Okay.
Thank you.
Yeah, Kirti, Dr. Vivek also mentioned MSUD diet for awaiting genetic results should be okay.
Okay.
And you have a sachet of branch chain amino acids.
Branch chain amino acids. Yes. Okay.
Yeah.
Yes.
All right. Yeah. Thanks,
Okay.
Kirti, and let us know about the genetic result once you get it.
Sure. Thank you very much.
All right. Thank you. And that's our last case. So we'll meet again on the 18th of August. Please send in your cases by the 16th. You can email me on that email over there. And once again, thanks everyone for joining in.
Thank
Dr.
you.
Mansa, thank you. Lokesh, thank you. Good evening and good night.
Thank you.
Dr. Eugene,
Bye. Eugene,
thank you
bye.
very much. Yeah. And we'll see you shortly in a fortnight's time.